Well, we had somebody who was wondering about preventive and diagnostic colonoscopies. So um, there are certain rules that you follow when we're dealing with the colonoscopy. So now we all are familiar with the nice little chart that's put in the CPT manual, which is very beneficial. Tag it, flag it somehow in your CPT book. So if you're studying, you can go straight to that because you know it will come up. But that is how to code specifically that colonoscopy if it doesn't get to a certain point, or if it did get to a certain point, what code is it? What do you use for modifiers and such? So anyways, this person just needed some clarification for outpatient hospital procedure. So a preventive, they know that that's, the doctor, they're documenting the H&P, the patient has no symptoms, and so they said, okay, we'll do a screening. Okay, that's preventive. Diagnostic, okay, there's something documented that says they have blood in the stool or something like that. So, okay, we need to go in there. This is diagnostic. We need to diagnose it and look at it and see what's wrong. That's diagnostic, okay. So what if they say the patient has rectal bleeding, but the treatment plan is to do a screening with a screening ICD-10 code as their diagnosis. So, so the case wound up being coded with 45380 with a 33 modifier, and we're going to go over all this. And their diagnosis was the screening. But their question is, well, if the doctor said there was a problem, they had rectal bleeding, why is it a screening? So should it be diagnostic or should it be the preventive screening? So we're going to kind of break this down a little bit. According to the American Gastroenterological Association, so the screening test is provided when that patient has no signs or symptoms. So, okay, you're 58, time for colonoscopy. You're not having any problems, so probably everything's okay, but we need to do it. So we're looking at the screening then. We want to make sure there's no problems. We're screening the patient to see if there's anything wrong. So even if they found a polyp or some kind of benign or malignant or some kind of cancer in there, some kind of problem that they found during that test, the intent doesn't change. It started as a screening. That's the codes we're going to use even though we found something while we were there. So the screening diagnosis is still going to be primary, and then that polyp or whatever is going to be secondary. So a diagnostic is performed according to the AGA when there's an abnormal finding, a sign or a symptom. It could be abdominal pain, it could be bleeding or diarrhea. Anemia is another reason why they would do a diagnostic colonoscopy. So on their website of AGA, they had some commonly asked questions and answers. So I thought, okay, I'm gonna snag one of these. What if the patient or their referring physician who called and said, okay, I need to get this patient in for a colonoscopy. They said, yep, they have no symptoms. Or you talk to the patient, they said, yeah, I have no symptoms. But then they come in the office and they say, well, yeah, but I had problems in the past, but I don't have any now. So that at that point, it becomes the physician's decision. If those symptoms or whatever they had in the past or what might have gone on previously is going to justify whether they are going to do a screening or a diagnostic procedure. So that's a little tricky, and that's the physician who's going to make that decision once they're there talking to the patient. What if they had polyps that were discovered on a past screening? However, when they come in now, they don't have symptoms. So that patient is asymptomatic, they don't have any symptoms, it's still considered a screening. Even though with the last time they had one 5 years ago or whatever, they said, yep, we found a problem, but it's okay, it's gonna go away or whatever. they don't have any symptoms or signs going on right now 5 years later. So it's again just a screening. So one reason why there's a big distinction between the diagnostic and the screening, why it's so important, is because of the Affordable Care Act. So when this came out, this was a mandate then that insurances for screenings, you're not going to make the patient responsible. So that's was a very important part of it. The Affordable Care Act, we're trying to promote people to have good health. And how can they have good health and have all these screenings performed if we're going to make them pay for it? So this came out and said, okay, you're not subjected to your deductible. You don't have to pay those 20% co-insurance or something like that. Please go have this test done. So a lot of times what happens is the patient knows this and they call the doctor and they go, well, I'm not supposed to have a deductible. You billed it wrong. We love hearing that in the billing department. You billed it wrong. And a lot of times they've already called the insurance company, and that might be what the insurance company's telling them too. Well, they billed it wrong. Well, not if the doctor found a problem. If the doctor found a problem, it's no longer screening, it's diagnostic. So that is something that the doctor should, or the staff should be explaining to the patient, is there's two different kinds. This will have some kind of patient responsibility. So screenings are usually billed with that diagnosis to indicate that it was screening, as well as a modifier. So they used modifier 33, preventive service. So we're trying to remember all of our codes that we send in are for statistical reasons. So this is letting them know the broad picture, the big picture going on here for the patient that day. It was screening, the intent is screening. Here's the modifier. This was a preventive service. Please don't bill them their deductible and their copays. So it's especially important with Medicare patients because Medicare, of course, we know uses HCPCS codes for some of our services. And there are two different HCPCS codes. G0105 means that that patient had a screening, but they're at a high risk. So Medicare preventive services, if this is something you deal with, I would definitely search out their website, which is wonderful. It's a wonderful tool for preventive services. It tells you everything you need to know. So it will tell you they can only have these every 10 years. So unless they have problems. So a high-risk patient is considered somebody who had a close relative, their brother, their mom, who had the colorectal cancer, or an adenomatous polyp. I know I probably didn't say that right, but or a family history of hereditary non-polyposis cancer, personal history of polyps, a personal history of cancer that of course bumps you up to your higher risk. Even if you have inflammatory bowel disease, IBD, Crohn's disease, ulcerative colitis. So some of these things say, wait a minute, you're in a different category now, you get to have this service done more often, where the G0121 is the other HCPCS code we're going to use for screening for Medicare patients, and which is why this is so important to distinguish between what service we have that we're performing. These are people who don't have a high risk. So with that, we're going to bill that Z12.11, that encounter for screening for malignant neoplasm of the colon. But so the question that they gave, though, in the very beginning, I brought it back down here again so we can remember what it was, is they coded it 45380 with a 33 modifier, the diagnosis of Z12.11. And so I just wanted to break this out a little bit more. Z1211 are encounter for screening, malignant neoplasm. 45380 is a colonoscopy, flexible colonoscopy with biopsy. So they did something while they were in there. And we only have the one diagnosis of Z12.11. Now remember, it said that our intent doesn't change. We can bill that Z code. If we really said this was screening, for some reason we just want to have another screening done, we did the screening diagnosis, we have the 33 modifier. But if we found something there because we did a biopsy, we need to have that second modifier in there indicating what we found. I'm not sorry, not second modifier, second diagnosis. I'm sorry. But the diagnosis, it was intent for screening. However, something was done. But the H&P indicated rectal bleeding. So a query should be done. Sorry to draw this out. Bottom line, surprise, surprise, you have to query the provider. We need more information. If there was rectal bleeding, did this fall into that category that it's the provider's decision? Said, well, it could be rectal bleeding from some other reason, maybe a medication or maybe a digital rectal exam, who knows? But was it specifically continuous rectal bleeding or, whatever qualifications that physician determined would fall under a screening or a diagnostic. So some of the links that I included were some of the information that I got some of this information from regarding colonoscopy screening versus diagnostic. So.
Do you need more medical certification and business training? Learn more at www.cco.us.